Welcome back, students. In this lecture, I'm going to introduce trauma and stressor-related disorders. To complement what is covered in the assigned reading for this week, we'll explore what happens after a traumatic event and how PTSD and related conditions develop. And most importantly, we'll learn how people can recover from these trauma and stressor-related disorders. I encourage you to pause throughout this video to reflect on what you're learning and how it relates to other content in this week's module. Let's first consider why it's important to study this at all. Traumatic experiences, unfortunately, are common, and estimates suggest that around 70% of people globally will experience a potentially traumatic event during their lifetime. Yet, only a subset of those individuals develop PTSD. Understanding the factors that determine one's vulnerability and one's resilience is critical for both science and compassion when we're considering how those with mental health challenges live their lives. Let's first begin by defining trauma, because I feel like the word is used often, but we want to make sure that we're talking about the same thing together. According to the American Psychiatric Association, trauma refers to exposure to actual or threatened death, serious injury, or sexual violence, whether this is directly experienced, witnessed, or if we learn about it happening to someone we care about. What's important to note is that trauma is not limited to a single event. It can be a single occurrence, like a car crash or a natural disaster, or it could be repeated chronic exposure, like ongoing abuse or living in a war zone. According to trauma-informed models of care, it's not just the event itself that is distressing, but the pervasive effect that trauma has. Emotionally, physically, psychologically, and socially, it leaves lasting consequences. Systems like the Substance Abuse and Mental Health Services Administration further define trauma as any incident or series of events that are emotionally disturbing or life-threatening and that have persistent adverse effects on one's daily functioning and well-being. When we talk about trauma in the context of mental disorders, we'll include a range of stressors from combat, violent assault, natural disaster, sexual violence, childhood abuse or neglect, and sometimes even complex relational trauma. Another definition that might be helpful for putting into perspective what is trauma is that trauma is any event where we feel our resources or our capacity to cope are far outweighed by the threat of the situation we are in. Before we look further into the impact of trauma and stressor-related disorders like PTSD, let's see how common traumatic events are in childhood and the lasting impact that they can have well into adulthood. A frequently used framework to capture childhood trauma is the Adverse Childhood Experiences, or ACEs framework. You may have heard of this if you took a lifespan development class. The original ACE questionnaire asked about 10 different types of adversity that one can experience before the age of 18. Emotional, physical, sexual abuse, emotional and physical neglect, household dysfunction such as parental separation or divorce, substance use, domestic violence, and mental illness in the home, or incarceration of a household family member, are just some of these things that were on the ACEs questionnaire. Research consistently shows that early adverse childhood experiences contribute to the phenomenon known as toxic stress, where the body's stress response system is chronically overactivated, leading to changes in brain development, immune system function, and regulatory systems throughout the body. If we look a little bit closer at the data for ACEs, we can see just how common they really are. In a recent large US survey using the Behavioral Risk Factor Surveillance System from the years 2011 to 2020, 63.9% of US adults reported at least one ACE, and 17.3% of adults reported experiencing 4 or more ACEs in their childhood. Among U.S. adolescents, those in grade 9 to 12, 80.5% reported at least one ACE, and 22.4% reported experiencing 4 or more. On a global level, a meta-analysis similarly found that over 60% of adults worldwide report experiencing at at least one ACE, with about 16% reporting 4 or more. These numbers highlight how common early adversity is, and now we'll look at how people can carry these experiences into adulthood and how it impacts both their physical and mental health. Because ACEs are strongly linked to poor mental health and physical outcomes, that's why these statistics are so important to consider. People with higher ACE scores have greater odds of depression, anxiety, PTSD, substance use disorders, self-harm, and suicidal behavior. The effects of ACEs are not just psychological. On the physical side, ACEs are associated with increased risk of chronic diseases such as cardiovascular disease, diabetes, obesity, and autoimmune conditions. Adversity early in life may alter physiological symptoms like inflammation regulation and stress hormone pathways, leading to chronic health burdens that persist well into adulthood. ACEs also show a dose effect, meaning that the more types of childhood adversity someone has experienced, the higher their risk for worse health outcomes later on in life. This just underscores the cumulative burden that trauma has on lives. Take a moment to reflect on this question. Feel free to pause the video, maybe jot down your thoughts and notes. Based on what you know so far about ACEs and their effect on health, how might early adversity shape someone's vulnerability to PTSD or other trauma-related disorders later in life? According to the National Institute of Mental Health in the US, about 3.6 adults meet the criteria for PTSD in the past year, while about 6.8% met it at some point in their lives. Globally, estimates suggest about a 5.6% lifetime prevalence for PTSD. What's interesting to note, though, is about 27% of people who are exposed to a traumatic event actually go on to show symptoms of PTSD. But by 3 months later, prevalence rate is reduced to about 18%. That will be interesting to consider when we talk about treatment and what recovery looks like for PTSD. PTSD is now grouped under the trauma and stressor-related disorders within the DSM-5, reflecting that it's defined by a traumatic event as the necessary precursor rather than purely fueled by anxiety. The DSM-5 criteria includes exposure to a traumatic event followed by symptoms in 4 different clusters: intrusion, avoidance, negative mood or cognitive changes, heightened arousal, and reactivity. Let's take a look at those 4 symptom clusters in a little more detail. Intrusion involves unwanted memories or flashbacks. Avoidance is efforts to avoid reminders of the traumatic event, like avoiding situations that may trigger memories, or avoiding certain locations or people altogether. Negative mood and cognition include the persistent negative beliefs and detachment from others. Arousal and reactivity include the hypervigilance, irritability, concentration difficulties, and sleep problems that people with PTSD can experience. In order to be diagnosed with PTSD, these clusters of symptoms must last over a month. Pause for a moment to consider which of these symptom clusters are the most visible to other people and which ones might remain hidden. Of course, PTSD is not the only trauma and stressor-related disorder. ASD describes the acute onset period from 3 days to 1 month post-trauma, where if symptoms persist beyond a month, the diagnosis may shift to PTSD. Adjustment disorders involve emotional or behavioral symptoms in response to a stressor, like a divorce or job loss. They don't reach the full PTSD diagnosis, but they still cause distress. We mentioned how not everyone exposed to trauma develops PTSD. Risk factors that increase one's likelihood of developing PTSD include experiencing intentional trauma like assault, a history of prior traumatic events, and being a woman. Protective factors include strong social support and quality coping resources. Early screening and psychosocial intervention can also help reduce the chronicity or chronic impact PTSD can have on one's life. Along with PTSD, many people also experience major depressive disorder, other anxiety disorders, and substance use disorders. Studies show that PTSD is also a strong risk factor in suicidal ideation. And in the video within this week's module where you hear about lived experience with PTSD, you can see that this is the case. This disorder causes distress long after the traumatic event, resulting in impairment across one's job, within their relationships, and impairments to their daily functioning. What's important to remember, however, is that PTSD is treatable. Trauma-focused therapies like prolonged exposure and cognitive processing therapy are evidence-based. SSRIs and SNRIs are pharmacological options for treatment, and the combined treatment of therapy and medication often yields the best outcomes. Research is still ongoing. However, psychologists are looking into newer treatments like ketamine therapy or MDMA-facilitated therapy for treatment-resistant cases of PTSD. But it's important to remember our considerations of what recovery from mental health challenges looks like, and it's not necessarily recovery from PTSD is returning to how one was before the traumatic event, but learning to live well despite their experiences with trauma. Unfortunately, stigma surrounds PTSD and other trauma-related disorders. People with PTSD may be dismissed as weak, told to just get over it or move on, or even be blamed for the symptoms that they experience. For example, veterans may face stigma if others interpret hypervigilance as aggression. Survivors of sexual assault may face victim blaming. This stigma not only harms one's self-esteem, but it also creates barriers to treatment. Culture can also play a powerful role in how trauma is understood and expressed. In some cultures, mental health symptoms may be minimized or explained in spiritual terms, while in others, trauma responses may show up as physical complaints like stomach aches or headaches. For example, research shows that Cambodian refugees who survived genocide often described their symptoms of PTSD as bodily pains and dizziness, while in Western contexts, the same experiences might be described as panic attacks. These cultural differences affect whether people recognize their experiences as a mental health concern and whether they feel safe seeking help. Because of these challenges, trauma-informed care has become a vital framework in mental health services. Trauma-informed care means assuming that trauma may be a part of a person's past and designing services that avoid re-traumatization. It emphasizes physical and emotional safety in the context of therapy, building trust between client and provider by offering choice and using a collaborative effort in therapy, and focusing on empowerment rather than control. For instance, a trauma-informed clinician might give a patient choices about where to sit in a therapy room, explain every step of an assessment before asking sensitive questions, and remember to validate the person's strengths and survival strategies. This shifts the focus from what's wrong with you to what happened and what can we do to help you feel safe now. To wrap up this lecture, PTSD and related disorders remind us that trauma leaves lasting marks, but people can also heal with understanding, compassionate support, and evidence-based interventions like progressive exposure, cognitive processing therapy, or EMDR. Recovery is possible.